Thank you so much, sir. Very good morning, everybody. So this talk I'm going to give today is very different from the talks which I conventionally give for two reasons. I'll be focusing on a very important aspect of pulmonary medicine nowadays is how to utilize AI optimally to assist and augment our clinical decision making. Second is the audience which I see in front of me. Generally, I talk to a podium full of pulmonologists. So today I'm talking to a very diverse group of people who have come here assembled to understand how we can improve healthcare altogether. So the talk is titled as Precision Pulmonology for Lung Node Diagnosis and Management. However, I'll also very briefly touch about the aspects in which AI is helping us in pulmonary medicine. So disclaimers, first thing, I am a hardcore clinician. So unlike my previous tech savvy speakers, I won't be able to talk about the technical aspects of how to develop an AI tool. I'll be talking about how we can utilize the tools which are there in. So whatever data I'm showing is original data. However, AI has been used to make these slides. Obviously, this is an AI conference. So we have utilized AI to make some of these slides and to augment the presentability of these slides. So setting up the context, why is lung nodule important is something which is very important for us to understand. So lung diseases, as we all understand, are on the rise. And lung cancer in particular, if you see, this is the Globocan data of lung cancer in India. Since the last 2 decades, the incidence of lung cancer is steadily increasing. And not only that, the mortality also is increasing. In fact, lung cancer is the leading cause of cancer-related deaths globally and in India. So it has an extremely high case fatality rate of 75%, which means that if we diagnose 4 patients with lung cancer, 3 people succumb because of lung cancer. So why is this problem? Why is this high case fatality rate? The main reason is that point B. Most of the early stages of lung cancers are asymptomatic. So the early stage of lung cancer is basically a nodule. So I'll talk about these nodules. So these lung nodules are asymptomatic in a vast majority of patients. So it is very difficult for a clinician to identify lung cancer when it is in early stages, and that is the reason why till today we lose a lot of patients whom we diagnose lung cancer, because we diagnose when it is too late. In India, we don't have a lung cancer screening program because of the population, the technical difficulties in starting an official lung cancer screening program. And also the epidemiology is fast changing. This is how lung nodules look. They're small, less than 3 centimeters. We usually need a CT to pick up a nodule, and CTs are not done for everybody. These are asymptomatic, so most of the lung cancers are undiagnosed, undetected in the early stages. So to improve the diagnosis of lung cancer, we have been working the last 2 years. In 2024, we started India's first lung nodule clinic, where every nodule which comes to us, we systematically follow them till we get a diagnosis. And then what we realized is, this is the first 100 patients data which we have sent for publication. 1/3 of the lung nodules are actually malignant. 1/3 is a very big number. So if you have 3 nodules, 1 is a malignant nodule. So then what did we do? In 2025, we wanted to improve our ability to pick up these lung nodules. Can we pick these nodules on a chest X-ray, which is done more often than a CT? So that is when we partnered with Cure AI. They have the model which is already developed, the QXR. So we tried to club this QXR into the clinical algorithm and see whether we're able to pick up more early stage lung cancers. So this is a real life story. This case was just 2 weeks from now. He was a 58-year-old gentleman, never smoker, businessman. He had not come to pulmonology. He had come to gastroenterology for a routine elective cholecystectomy, gallbladder surgery. He had no lung symptoms, no weight loss, no fever, no family history of lung cancer, and no history of tuberculosis. This was the X-ray. X-ray was done as a part of pre-surgical evaluation. It was not done because he had lung problem. So the X-ray was reported as normal. In fact, if the X-ray comes to me, I would have said this is a normal X-ray also. But then, since we have this QXR embedded in our algorithm, each X-ray is read by an AI agent also, and then the AI picked up something which human eye couldn't pick up. So it picked up a small circular lesion and said it's a nodule, it's a high risk nodule. So then all these cases then are referred to a lung nodule clinic, and then a CT was done. Lo and behold, there was actually a nodule there. So this was the small nodule. It was around 12 millimeters into 13 millimeters in diameter, volume 2 ml. Then we use these risk prediction models, and then it is 6 to 7% malignant risk. Anything above 5% is intermediate risk, and then we went ahead and did a biopsy. Again, sampling these small lesions is not very easy, so we have several technological gadgets to help us. This is the navigational bronchoscopy. Then we have thin scopes, cryoprobes, and a cone beam CT, where we do a CT intraoperatively to make sure we're at the correct target. And then we sample the lesion. This was the biopsy. Biopsy turned out to be a lung cancer. So generally, lung cancer is a diagnosis which is equivalent to death, because as I've said, 75% case fatality rate. But for this particular case, it's not a bad news, because we have picked it up at when it is in stage 1. So now this patient is going to come next week, because he has to undergo treatment. He is in a stage where we can resect the cancer and it is in a curable stage. So now, did AI actually save this man's life? The answer is yes. So had AI not been there, we would have not picked up the nodule on X-ray. He would have done ahead, he would have gone leading a normal life till the nodule increases, becomes symptomatic. We would have diagnosed when it was stage 3, stage 4, when it is not curable. So that is how AI is actually augmenting our ability to pick up early stage lung cancers in clinical practice. Now, why can AI be better than humans? One, subtle abnormalities which a human eye can miss are often picked up by AI, and the vice versa is also true. It is not that every X-ray AI will pick up. AI doesn't get fatigue. This was also spoken in the previous lecture by Mrs. Sapna. So there is no element of fatigue in it. It learns from much larger databases than a human trainees, and AI also can accurately measure sizes and volumes. Now this is the workflow at our hospital. Dr. Vipul is also sitting with me here. He runs our AI nodule clinic, and then we have radiologist who obviously supervises everything which is interpreted by AI tool. This is the QXR. So we have three tools: QXR, QCT, and QTrack. All of them developed by Cure AI. QXR is the basic screening tool. So all X-rays are run through the QXR. It picks up not only the nodules but also several other abnormalities. So whenever X-ray picks up flags a high risk nodule, a CT is done. CT also interprets the nodules, and then we have a separate software called QTrack. This is for the lung navigator. So it's an app to ensure that these patients are followed up at the appropriately timely. And then it also monitors the volumes and sizes of these nodules. So these are the 3 tools, and this is a simple our flow in the Yashoda Hitec City. So each and every X-ray is run through the AI. It gives a report as nodule yes, nodule no. If nodule yes, is it low risk or high risk? If it's a low risk, usually we don't chase these nodules because it will be too much of an effort to chase every nodule picked up. If it's a high risk nodule, then the navigator, we have appointed a dedicated navigator who ensures that this person, wherever he is in the hospital, in the entire 15-floor hospital, he reaches the nodule clinic, he meets Dr. Vipul. Dr. Vipul then goes through the history, X-ray, decides whether a CT is needed or not. A CT is done, CT is interpreted. If a nodule is there, then we follow the conventional nodule algorithm, whether to biopsy, not to biopsy, and then till we get a diagnosis, these patients are followed. So in the last 1 year, 40,000 X-rays have been screened. Important point is that these are not high risk people. Very different from the lung cancer screening programs where you choose patients who are smokers. These include people who are asymptomatic, who come for health checks, who have no smoking history. And then if you see, of these 40,000 X-rays, there were 2,000 nodules picked up on X-ray, 300 high-risk nodules, which means you have to screen 110 X-rays to pick up one high-risk nodule in a low-risk population. And then of these 300 patients, 150 consented to get a CT. Not everybody consents. And then 40 were actually true positives. Again, a point to note, not every AI picked abnormality is a true positive. There can be false positives also, but I think the effort is justified, because even if you diagnose 1 in 3 as true positives, if we can pick up a large number of early stage lung cancers. I think that, that's how I look at it. Couple of other examples in the interest of time. So this is a young lady, pre-employment health checkup, X-ray was normal. AA picked up an alert, CT showed a nodule, again sampling was done, this was an asymptomatic tuberculosis. So had we not picked this thing, she would have spread the disease to a lot of other people because she stays in a dormitory. 71-year-old reformed smoker, again routine annual checkup. This is not a symptomatic person, routine annual checkup. AI picked up a nodule, human eyes couldn't pick up a nodule, CT confirmed a nodule, again biopsy done, confirmed as stage 1 lung cancer. This person already underwent a surgery and is cured. So this is how AI is helping us to pick up early stage diagnosis, early stage lung cancer. In India, early stage TB. We're talking about eradicating TB. How can we eradicate TB? Only if we pick it up early. So this AI is helping us diagnose lung diseases early. So beyond nodules, a couple of minutes I will take, not only for lung nodules, we are also using AI for a lot of other reasons. One, to quantify the extent of abnormalities on a HRCT. This is another area where AI is significantly helping us. So at our hospital, we have, as of today, incorporated 2 developed AI tools. One I have already said is the Cure AI. Second is a group of softwares by 4D Medicals, the lung texture analysis and the lung density analysis. So I will not spend much time. So this is LTA, where the HRCT is interpreted by an AI alongside a radiologist. It gives us the pattern, and more importantly, not only the pattern, it quantifies the ILD. This is very important for us because we are a referral center for ILDs. We also do a lot of lung transplants. It's very important for us to monitor the progression of ILD, and these AI tools actually quantify ILD better than a human eye can do. So also we are using AI now to pick up COPD. Again, this is another study which we have recently finished. This is an ambispective study of 55,000 X-rays, where 1,000 paired X-rays and PFTs were done, where AI picked up an early COPD, and then we have shown that 50% of the times AI is correct in diagnosing COPD. I think with this I will end my talk by saying that AI, in the last 2 years since we have started using it on multiple fronts, I have only spoken about the clinical front, it's helping us diagnose diseases earlier. Number 2, it is significantly helping us to quantify them better. So quantification is always a problem for a clinician. It helps us quantify better, and by doing these 2 things, it is helping us give a better treatment decision to our patients. So it is supporting our clinical decision making. So I'd like to end by saying that when an artificial intelligence is added to human intelligence, I think this is the best way forward. So AI is live in Yashoda Hitec City pulmonology. So we've already employed 2. We are also partnering with several companies to develop Indian AI platforms. All of these were developed on non-Indian patients. So we want data sets from India, and we are actively working with several companies. AI is definitely picking up smaller nodules. I have shown live examples from our AI lung nodule clinic. However, a point to note is that the clinicians remain the final decision makers. AI augments the human care. I think today it cannot replace it completely, but definitely it is assisting us a lot. So thank you so much for patient hearing, and